had to move to eat. So the movement was inbuilt in their life. But here now we are sitting and working also sitting, and they do everything sitting. That is what is the problem is. That sitting is not bad. Don't feel bad about it, and enjoy the day. So next we'll move on to the important topic of cancer therapy and osteoporosis. My focus today is I'm not going to discuss on about metastatic bone disease, which is common in many cancers, including breast cancer, and that is a disease by itself, and that requires a totally different clinical approach. And many cancers, including multiple myeloma and many other cancers, increase the fracture risk by a very different mechanisms, which we are not going to discuss today. We discussed today about the most common cancers which affect the bone health, like cancer breast and to a certain extent cancer prostate. And cancer breast and prostate, they are the most successfully treated cancers nowadays. And chemotherapy used in many cancers, including breast and prostate cancer, can be gonodotoxic. And medical and surgical castration or gonadal ablation is very common form of treatment for these endocrine cancers. And gonadal suppression is routinely practiced in these cancers. And estrogen and androgen are targeted in therapy and recurrence prevention. And these are the very vital hormones to influence the bone health. And the survivors are at a higher risk of fractures. And the cancer itself can cause osteoporosis, and senescence induced by chemotherapy also can contribute to osteoporosis. See, when we give chemotherapy, it kills the cancer cells, but it also influences some of the cells which can actually accelerate senescence. So people who receive chemotherapy, to a certain extent, some of the cells do age prematurely, and we thought that they are very benign cells floating around doing nothing. They are zombie cells, but they do produce chemical signals, and which can alter the bone remodeling and can lead to weaker bone. And another factor, the cancer itself can lead to osteoporosis by producing particularly breast cancer. 60% of the breast cancer produce what is called as a PTH related protein, which go on to stimulate osteoclast. And they also influence osteoblasts to produce more rank, and rank can go and bind to rank ligand and promote osteoporosis. And osteoblasts also produce a lot of growth factors which can actually stimulate the cancer cells. So this vicious cycle can keep on going and perpetuate the osteoporosis in a cancer situation. So breast cancer is one of the most curable cancers. 80% of the women who suffer from breast cancer can be considered cured with a good 10-year survival. And we are discussing here about non-metastatic breast cancer. Metastatic breast cancer have a poor prognosis and require much more intense bone-directed therapy apart from other therapies. There are many causes of osteoporosis in a breast cancer patient. The chemotherapy, which I had already told you, can be gonodotoxic. And radiotherapy also can have influence on bone, either directly by damaging the gonad, or also by very indirect methods which can damage the bones. And the cancer itself, we had discussed how cancer itself can increase the risk of osteoporosis. And we also discussed about chemo-induced senescence and its influence on the bones. And most of the cancer regimens also use glucocorticoid at a higher dose for a short period. Any dose more than 2.5 milligram given longer than 3 months can influence the bone architecture. And we generally give much more steroid during these chemo regimens. And of course, the breast cancer therapy involves post-treatment, involves adjuvant endocrine therapy in the form of tamoxifen. Tamoxifen is a very interesting molecule. If it is given in premenopausal women, actually it increases the bone loss because it's a weak estrogen analog. But in given in a postmenopausal, probably it can be bone protective. And they also use lot of GnRH agonist and antagonist to suppress the ovarian function, and that can cause temporary menopause, and that can accelerate the bone loss. And the last drug, which is the most popular drug used now, letrozole and anastrozole, they are aromatase inhibitors. Even post menopause, women do produce estrogen from fat, and this estrogen can influence the breast cancer and increase the risk of recurrence. And to make sure that the estrogen is not available to target the breast tissue, aromatase inhibitors are used widely for 5 to 10 years. And this is the data. Fracture risk definitely increased by 20% in breast cancer survivors. And this cartoon it tells us about the naturally occurring bone loss. In men, it occurs at 0.5 percent per year. Postmenopausal women at 1% a year. At menopause, it increases to 2 to 3% per year. But when we use cancer therapy, it's leaps and bounds above the normal bone loss. And there is a good evidence from studies to say that drugs like anastrozole, letrozole definitely increases the fracture risk when it was compared with tamoxifen, which was the standard of care when these drugs were introduced. This is a busy slide which talks to us about many risk factors, including general risk factors and risk factors which occur during cancer chemotherapy. You all know about the gender, low physical activity as a contributing factor to weak bone. And the physical activity is very important to achieve the peak bone mass. If our daughters and girls are not physically active, they are not going to achieve their peak bone mass. The peak bone mass is achieved around 2030s, and it stays until 40, and around menopause it drops. So if they don't reach their peak menopause, so they can reach menopause at a much lesser peak bone mass, and they can reach the fracture threshold fairly early because they lose 3 to 5% of the bone per year during the menopause time. Many drugs like methotrexate at high dose, cyclophosphamide, cyclosporine can accelerate the osteoporotic process, and chemotherapy can be gonodotoxic. So this is a very broad slide which gives us the risk factors. This is one comprehensive slide I want to discuss. So this is the kind of algorithm, and this is the pathways. So in a patient who is see a breast patient or a prostate cancer patient, and the multiple risk factors, like which are non-modifiable risk factors, which were discussed in the previous talks, and modifiable risk factors again discussed by Professor Shashank and Dr. Paul. They all contribute to osteoporotic and fragility fractures. Then what is specific to these patients is breast cancer patients who receive aromatase inhibitors like letrozole or anastrozole, GnRH agonist like leuprolide and goserelin, chemotherapy, glucocorticoid, oophorectomy. All these things can cause inhibition of osteoblastogenesis, and they can induce osteoblast apoptosis, increase osteoclastogenesis, and increase the osteoclast survival. So this is a good recipe for osteoporosis. And the pathways upgraded are rank and rank ligand pathway, which is the pathway for osteoclast activation, which is targeted by drugs like denosumab, and they can lead to very rapid bone loss, up to 6 to 8% reduction in bone mass in the first year of therapy. So that's a huge drop. So this is very important. So this can contribute to already somebody is having a risk factors. This can add significantly to the risk factor and contribute to the fracture risk. And the very similar process happens in the prostate cancer as well. So androgen deprivation therapy is the cornerstone of prostate therapy, and they also use chemotherapy, glucocorticoid, and orchidectomy. then leads to a very similar decrease in osteoblastogenesis, which is pro-bone forming, increased osteoclastogenesis, which is bone resorptive pathway, and leads to rapid bone reduction, up to 5 to 10% bone reduction happens. And particularly in men, sudden decrease in testosterone can lead to a significant bone mass, muscle mass loss, leading to sarcopenia, and sarcopenia can lead to increased risk of falls and contribute to fracture risk. So muscle is actually generally ignored organ in metabolism. I think Dr. Paul and Shashank would agree that muscle is being considered as a very active endocrine organ, and myokines and so many things can contribute to general well-being. Again, this is a slide which I already discussed. This is the loss of spine BMD per year, which when you look at the chemotherapies, aromatase inhibitor therapy and aromatase inhibitor therapy plus ovarian ablation can lead to a significant amount of bone loss per year compared to the normal postmenopausal bone loss. So, when the breast cancer strikes women around postmenopause, and they have their traditional risk factors for osteoporosis, and the cancer and the cancer therapy together contribute a large amount of risk, and these women with the current treatment survive long enough to get the osteoporosis and osteoporosis fracture. So these are the people. I think oncologists are now much more aware of this entity, and they are routinely using bone protective agents during their 6-monthly follow-up nowadays. I can see every 6 months they get a zoledronic acid infusions or a denosumab infusions. So that is good. But if there is a patient who is missed out, I think when we as a clinicians, when we see these patients, I think we should take cognizance of this and address these patients. And fortunately, the vicious cycle, tumor bone vicious cycle, which can lead to the perpetuation of osteoporosis, and also which can worsen the cancer. Somehow what should I say? Rapidly reabsorbing bone, or where the osteoporotic process is happening, that seem to attract cancer cells also into it. So that can be prevented by bone resorption inhibitors like bisphosphonates and denosumab. So this is the current guidelines of treatment. So breast cancer, prostate cancer and other tumors treated with hormone associated treatment associated with accelerated bone loss like gonadal deprivation therapy. And we need to assess the osteoporosis risk factors, like how we assess in a postmenopausal woman, and that would include FRAX evaluation. And you do a DEXA. If the DEXA looks very good, the bones are looking stronger, the T-score is more than -1, then you require non-pharmacological approach and periodical monitoring of maybe every year we can, because the bone loss can be rapid when they are using these drugs. We can do this guideline says every 2 years, but we can do it every year as long as it is done by the same lab and we know the difference, to know how to get the difference, like what Puneet was alluding to. And if the bone density is weak and it is less than -2.5, then there is no question that patient require treatment, and they require both pharmacological therapy either with bisphosphonates or denosumab, and along with non-pharmacological measures. When the risk is in between, again these are the patients who require treatment because these are high risk candidates and they require pharmacological treatment and periodic assessment by DEXA and bone resorption markers to assess our treatment response. What are the commonly used drugs in prevention of osteoporosis in non-metastatic cancer? If you look at the drugs, the commonly used drugs like alendronate at 70 milligram per week, can be used. It was used, and there are data to support that they prevent fractures. And the most popularly used drug in clinical trials for some reason is Residronate, 35 milligram per week, and they also had data to show that they improve the bone strength BMD and reduce the fractures. And Ibandronate also has been used. But the most popular and most powerful drug is intravenous zoledronic acid. For some reason, in oncology circles, most of the studies were done with 4 milligram every 6 months. This 4 milligram 6 months probably must have got into oncology way of thinking, is because they use a much higher dose, like 4 milligram every month in a metastatic bone cancer. If breast cancer has already metastasized to bone, they use 4 milligram every month, then every 3 months, then every 6 months. So it has somehow they have in all the studies they have studied 4 milligram every 6 months. That becomes 8 milligram per year. But I feel that 5 milligram once a year, which we use for osteoporosis, should also work. Why? Because the drugs which are considered much less potent compared to intravenous drug like Residronate and Alendronate seem to have a positive effect on the clinical trials on aromatase inhibitor users. So if 35 milligram of Residronate work, 5 milligram zoledronic acid should work. So at least 5 milligram of zoledronic acid per year, or in oncology literature 4 milligram 6 monthly are used. And the new kid on the block is denosumab, which is 60 milligram every 6 months, is a drug which is a very powerful anti-resorptive drug, and it in head-to-head trials it had performed slightly better than zoledronic acid, particularly in BMD increase in the hip. In the spine, both are fairly equivalent. To if somebody has a significant hip fracture risk, denosumab can slightly score over other drugs to prevent fractures. So how long to treat? In a premenopausal woman, as long as ovarian suppression is continued, we should continue the anti-osteoporotic measures. If the menstruation recurs, some bone recovery is possible, then probably we need to monitor and we can withdraw therapy. And withdrawal therapy is again a big problem. It is very easy in bisphosphonates, but if you are chosen to use denosumab, the withdrawal can lead to rapid bone loss, particularly in the vertebral in the first year after withdrawal, and that can increase in multiple vertebral fractures have been reported. So if we have to stop denosumab, you have to give zoledronic acid, and then only we can stop. So we cannot stop abruptly. In postmenopausal women, we have to continue as long as aromatase inhibitors are continued. Nowadays, the usual duration used to be 5 years. Nowadays, it's getting extended up to 10 years in the oncology literature. So most of the patients, our own patients who are having breast cancer therapy, they are on these medications for at least 10 years nowadays. So we need to reassess the fracture risk after discontinuation and decide whether we need to continue to use anti-osteoporosis measures, or whether we can give a drug holiday. To conclude, ladies and gentlemen, cancer breast and to a certain extent cancer prostate, patients survive long enough to develop osteoporotic fractures, and osteoporosis and fracture risk are higher than general population. And bisphosphonates, if begun immediately along with aromatase inhibitors, seem to increase the survival compared to aromatase inhibitors given alone. This is still not yet become a guidelines, probably because use of bisphosphonate seem to reduce the incidence of a new bone metastasis and thereby improve the survival. Even otherwise, the bisphosphonate usage seemed to give some survival advantage even in postmenopausal women. So using bisphosphonate can be have some survival advantage as well. And oral bisphosphonate and preferably IV zoledronic acid are the preferable drugs. And denosumab is also an attractive option. As I told you earlier, remember to switch to zoledronic acid after when you decide to stop denosumab. You have to literally overlap, and sometimes if you have given denosumab for long enough, and even zoledronic acid may not be able to really prevent the rapid bone loss, so we may have to taper the denosumab from 60 milligram 6 monthly. We can give 30 milligram 6 monthly for a couple of doses, and then so that the rank level in the blood comes down, then you can zoledronic acid can work better. And the cancer survivors, they have fought the cancer and they have survived, and they should not have the ignominy of having an osteoporotic fractures. It's all our responsibility to make sure that this is looked at and give them a strong bones and better quality of life. Thank you very much.